Hi everyone, welcome and thank you for joining us today for this very special webinar with Dr. John Pauling, a consultant rheumatologist with a wealth of experience in scleroderma Raynaud's who has worked with SLUK many times. So I'm Annabelle, if you do not know, I'm the Executive Support Officer at SLUK. And so today, Dr. Pauling will be giving a presentation where he discusses different forms of Raynaud's phenomenon and the various methods used to differentiate between primary and secondary. He will also discuss how the term Raynaud's phenomenon may be contributing to diagnostic delay in systemic sclerosis. After this, there will be a Q&A session. Please feel free to put your questions in the Q&A button below, and we will get to them after the presentation. Please be aware that we will be unable to answer any question that might be too specific to yourself, and questions will be answered anonymously. At the end of this webinar, just to let you know, I will be giving a short presentation just about our updated Raynaud's App Star, so stick around if you want to hear about that. But so without any further ado, I will hand us over to Dr. Pauling, and thank you.
Well, thank you very much for inviting me to talk with you today, and it's great to see so many people online. I hope you can see my first screen. And so I was given the brief to talk about exploring Raynaud's phenomenon, and so we ought to start by thinking about what Raynaud's phenomenon is. So this is Maurice Raynaud, and about 150 years ago he described 25 cases of impaired circulation in the fingers of people's hands. And these 25 cases ranged from mild cases, such as case 1, and then they got progressively more severe. So this is case 1, and he described a young lady who, under the influence of a very moderate cold, even during summer, would notice her fingers losing all of their blood, becoming blanching or becoming white, becoming numb. This phenomenon happened often without reason. It lasted a variable period of time and then terminates by a period of very painful reaction during which the circulation is re-established. And this is the red phase of Raynaud's that some people experience, where after an attack of Raynaud's, the blood vessels, having been clamped down too tight, actually open up too much and allow too much blood to flow into the fingers, which can actually be, as Raynaud described, can sometimes be reported as one of the more painful aspects of this phenomenon. This is the 25th case he described. So he described a young woman who, at the age of 7, had developed a fever and gangrene, and her hands and forearms had withered away up to the commencement of the elbows, so that she only had 2 stumps left. And he gives this very powerful description of this young lady presenting to the assembly with her mummified hands in her pocket, which she actually got out and demonstrated to the people in the audience at the time. Now, I hope nobody on the call has experienced anything as severe as this, and you may well be wondering why I'm even mentioning it here, but the reason is that from this point forward, the term Raynaud's phenomenon has been used to describe reduced circulation in the fingers that can range from a fairly benign but intrusive conditions such as primary Raynaud's phenomenon, which some of the people on the call will be experiencing, to more significant forms of impaired circulation in the fingers, in which digital damage to the actual tissues of the fingers can occur. And that is certainly the case in systemic sclerosis. And we'll talk more about the links between Raynaud's phenomenon and systemic sclerosis. And Annabelle talked about diagnostic delay, and we know this is an issue in conditions such as systemic sclerosis. And I think some of this can be traced back to the fact that Maurice Raynaud, his phenomenon, has come to be used interchangeably to describe fairly benign and common conditions, but also severe forms of or severe conditions in which impaired circulation to the fingers occurs. So this is the spectrum of Raynaud's phenomenon as we know it today. There is primary Raynaud's phenomenon, by far the commonest form of Raynaud's. It affects around 5% of the general population, although that can vary, and I'll talk about that in a couple of slides' time. But the key thing with primary Raynaud's phenomenon is that there should be no underlying disease driving the impaired circulation in the fingers. And so I've written here about 1 in 10 of the general population. That's because actually primary Raynaud's phenomenon is far more common in females than males. And so it's probably around 1 in 10 generally, but 5% generally, about 1 in 20 generally, but up to 1 in 10 of the female population in the UK at least. And then there is secondary Raynaud's phenomenon, and we use the term secondary because in these conditions, the Raynaud symptoms are secondary or caused by an underlying health disease. And many of you on the call will have lived experiences of secondary Raynaud's because of systemic sclerosis, but rheumatologists need to be aware of many other conditions that can cause Raynaud's phenomenon. And this includes endocrine or hormonal problems, particularly hypothyroidism, where people have insufficient thyroxine in their bloodstream. And actually that can be caused by autoimmunity, and some people with systemic sclerosis also have hypothyroidism or reduced thyroxine production. It can be macrovascular, so this is involvement of the large blood vessels, and later in the talk I'll be talking about microvascular disease as it occurs in systemic sclerosis. And when I use the term microvascular, I'm thinking about the blood vessels that are only visible with a microscope, so the type of blood vessel that wouldn't be visible to the naked eye. Blood disorders can cause secondary Raynaud's phenomenon. Sometimes some of our medical interventions can actually lead to Raynaud's phenomenon, particularly people who've had chemotherapy. Some common blood pressure controlling medications, particularly beta blockers, can also precipitate Raynaud's phenomenon. And some of the drugs being used to manage ADHD are an increasingly common explanation for Raynaud's symptoms in our clinics. Neurological problems can cause Raynaud's phenomenon. So this is compression of the nerves or damage to the nerves that supply these blood vessels and are involved in the regulation of the size of the blood vessels. So if these nerves are pressed on or become damaged, they can actually encourage the blood vessels to vasoconstrict or narrow. Occupational, particularly vibrating tool use, can cause Raynaud-like symptoms. And then almost finally, the autoimmune rheumatic diseases. These are a very common reason for Raynaud's phenomenon in a rheumatology clinic, but they're actually quite rare. So in the case of systemic sclerosis, work that we've done funded by SRUK has demonstrated that in the UK, at least, it occurs in about 1 in 5,000 people. So probably less common than some of the conditions outlined or listed above. So this is a fairly old study from over 30 years ago, but it described a Raynaud's clinic in a secondary care setting, so in a hospital setting, and what type of patients were referred to those clinics. And what was interesting was that about half of the people who were presented to this Raynaud's clinic in Oregon in the US had no underlying disease, had what we would consider to be primary Raynaud's phenomenon. So certainly as rheumatologists and as hospital-based consultants, at least half of the diseases we're seeing in the clinic are secondary Raynaud's, even though they are by far the rarer forms of Raynaud's in the general population. Of the people with secondary Raynaud's, roughly half have an underlying autoimmune rheumatic disease, and then the other half have any one of these other conditions, some of which I've mentioned already. So rheumatologists, obviously, we're primed to look for the connective tissue diseases, conditions like systemic lupus erythematosus. PSS is an old-fashioned term for progressive systemic sclerosis. So you can see that by far that's the commonest cause of secondary Raynaud's caused by one of the autoimmune rheumatic diseases that we see in the clinic. So let's think first about primary Raynaud's phenomenon. So I've already mentioned this is a benign but intrusive vasospastic disorder. And what I mean by that is this tendency of the blood vessels to clamp down in response to cold exposure or emotional stress. But the key thing with primary Raynaud's is that there shouldn't be an underlying disease or condition driving those symptoms. And Raynaud's phenomenon, or primary Raynaud's phenomenon, typically comes on in early adulthood. I think that's one of the most important clinical features. It usually presents in teenage years or early 20s. And it runs in families. And this has kind of led to us suspecting that some people with primary Raynaud's phenomenon have an inherited vasospastic tendency, so that there must be genes running in their families that are encouraging the blood vessels to be hyperactive to cold and other stimuli. And interestingly, work done in the US has shown that Raynaud's symptoms are far more common in first-degree relatives and also second-degree relatives of people with systemic sclerosis. So people listening in today who have systemic sclerosis, their family members are about 6 times more common to have symptoms of Raynaud's, and their second-degree relatives are roughly twice as likely to have Raynaud's symptoms. So there's certainly important, or there may be important links between Raynaud's symptoms or some of the genes leading to Raynaud's phenomenon and some of the genes also associated with underlying autoimmune rheumatic diseases. And there was a large study done of a UK twins database that found a high concordance of Raynaud's phenomenon in twins experiencing this. And they did use this study to identify one possible gene, this nitric oxide synthase gene. Nitric oxide is a very powerful vasodilator, and they found an abnormality in one of the genes that may account for some of this inherited risk of Raynaud's symptoms. But I think in clinical practice, it's certainly more complex than this. And one of the things that investigators have noted for some time is the huge variation in prevalence estimates of Raynaud's phenomenon. So in some countries, if you do a study saying how common is, get rates as low as 2%. Countries, or in other studies, you get rates of Raynaud's phenomenon of 22%, a 10-fold difference in the estimated prevalence. So what could account for this? Well, Hildegard Mariek was a US-based rheumatologist who undertook a community-based questionnaire of nearly 1,800 patients or people within the community of South Carolina. And she asked them questions about whether their fingers were unduly sensitive to cold and whether they also changed color. So about 10% of local population, South Carolina, which has quite a tropical climate, reported cold sensitivity. We certainly don't need to have all 3 color changes of white, blue, and red to diagnose Raynaud's. And you can see that actually 1 in 1,000 people in the community will report such symptoms. But if you look at just 1 or 2 color changes alongside cold sensitivity, she found that in Charleston, in South Carolina, the overall prevalence of Raynaud's phenomenon amongst females was about 5.8%, so about 1 in 20. And you can see that the mean January temperature in Charleston is about 8.8 degrees Celsius. And she replicated this study using the same questionnaire as in other parts of Europe. And this Tarentaise is nestled in the foothills of the Alps, so they have much colder winters. And you can see if you use the same questionnaires amongst people living in colder climates, you get higher prevalence of Raynaud's phenomenon, so 20% in this group. And this study that identified a prevalence rate of 22% of people having Raynaud's phenomenon was actually a Scandinavian study of young women. And obviously they have very cold winters there as well. As with many aspects of medicine, it's never quite as simple as this. So she did replicate this study in Estonia, where they have bitterly cold winters, mean daily January temperature minus 6.8 degrees Celsius. And yet, interestingly, the prevalence of Raynaud's within that community back in the 80s was actually lower than you'd expect. So there's always anomalies, and it just demonstrates the complexity of these situations. There are societal, social, and cultural factors that also influence how, and also how well people learn to adapt to cold winters, that can influence how people report to this type of questionnaire-based study. So this is the type of patient who may come along to clinic. So this is a young lady in her 20s with a 2-year history of Raynaud's phenomenon. This ANA, anti-nuclear antibody, is a test I'll come back to later in the talk. It's a test that is very important when trying to diagnose autoimmune rheumatic diseases such as systemic sclerosis. So that was negative. Inflammation markers normal. There was no damage to the skin at the ends of the fingers. You can see here, this is a thermal image that looks at the temperature of the fingers and the back of the hands. And you can see the fingers are very cold, about 23, 24 degrees Celsius. This is at rest. The back of the hands around 30 degrees. When you remember that our core temperature is 37 degrees, so the fingertips really should be really pink, on a thermal image at least, should be very pink or red or even white at the top of this scale, would more closely approximate with our core temperature. Her Nailfold capillaries, and I'm going to be talking more about this later in the talk, looked very normal in terms of their size and shape. So these aren't the changes that you'd expect to see in somebody with a condition like systemic sclerosis. Now, the bit of the history I haven't told you about is she'd actually been on a health drive and had lost a lot of weight, and her body mass index, or BMI, had dropped to 17.2, which actually classifies her as being underweight. A healthy BMI is would be in the low 20s, so 20 to 25 would be considered a healthy BMI. So she was quite underweight. So could this actually just be an entirely normal thermoregulatory response? So I mentioned the core temperature of 37 degrees. We here in the UK, we live in a climate that regularly gets below 15 degrees, as it is today, you know, and colder during the winter. And so we've developed various ways of adapting to live in a cold climate. We built shelters and we wear clothes. But our bodies have also come up with ways of adapting to help us live in these cold climates. And in our fingers, in the tips of our fingers, we have these arteriovenous anastomoses, which are these thermoregulatory blood vessels that, when we're overheating, they dilate open to allow heat to escape from our fingers. But when our core temperature is threatened for falling, these blood vessels clamp down very tightly and significantly restrict the amount of blood flowing into our fingers and elsewhere. So this thermal image in the middle of the screen here is actually a short video. It's my hands, and it's going to show you what happens to my fingers when they're exposed to a modest cold of 20 degrees for 1 minute, and how they warm up. And you'll see the fingers go very cold, and then you'll see the arteriovenous anastomoses shut down, vasoconstrict, and then open up, which will help the blood flow back into the fingers. And I'm not going to make you sit here for 15 minutes. So I've sped this up so it's over about 15 seconds. So you see the fingers go very cold, and then these arteriovenous anastomoses shut down, and then they open back up. And you can see that actually by the end of the 15 minutes, the fingertips are actually probably a bit warmer than they were at the start. And this is part of, we call that the reactive hyperemia that occurs following cold exposure. And that's sometimes the phase at which the fingers can feel quite painful in people with Raynaud's phenomenon. So in the lady I was describing, you know, is what's going on in her fingers actually a very appropriate thermoregulatory response to cold? And one of the really seminal pieces of work that looked at primary Raynaud's was actually undertaken nearly 100 years ago by Allen and Brown, and they described 150 people with Raynaud symptoms. And they found that actually nearly half of that group that they examined were underweight. Only a very small number of the population they looked at were overweight at that time. And when they looked through the case records, they found notations of malnutrition, underweight, and emaciation made within the medical record. And Hildegard Marieke, who undertook the community-based studies that I was describing, she also I noted that people with Raynaud's phenomenon in her community-based surveys often had a lower BMI than people who didn't have Raynaud's symptoms. And this work's been replicated in recent years by a Dutch group, and they noted that if you had a BMI of 18.5 or less, you were 3 times more likely as a woman to have Raynaud's symptoms. This odds ratio at OR tells you how many fold times likely you are. If you're a man and had a BMI of less than 18.5, you're actually over 5 times more likely to have Raynaud's symptoms. Whereas if you had a BMI of over 30, which would be clinically classified as obese and certainly overweight, the chances of you having Raynaud's symptoms was actually brought down by about 70%. And if you're a man with a BMI of 30, you're 80% less likely to have Raynaud's symptoms. So our weight and thermoregulatory considerations are very important, and the temperature of the environment we live in are very important in dictating the likelihood of us having Raynaud's. And certainly some people with Raynaud's symptoms, their symptoms are being primarily driven by this thermoregulatory response that's where their brain is sending signals to the blood vessels in the fingers to shut down in response to cold. And the reason for that is that if our core temperature is threatened, it can affect our heart's ability to keep beating. So it can be a life-saving measure that's adopted. So what else may be contributing to what we might otherwise consider primary Raynaud's phenomenon? So a number of studies have identified an increased cardiovascular risk amongst people with Raynaud's, including the work I was describing by Hildegard Marieke. It's thought to be about 50% increased risk of major cardiovascular events in people who have cold sensitivity and blanching of their fingers. And you can see that in the Oregon study that this Raynaud's clinic in the US from over 30 years ago, where an underlying condition was identified, actually atherosclerosis or hardening of the arteries was actually the commonest cause for secondary Raynaud's. And but I think there are a lot of people who may otherwise be called primary Raynaud's phenomenon because there isn't a known underlying disease who atherosclerotic disease, a hardening of the arteries, could be important for. And this was recently identified to be an issue in a big meta-analysis. They looked at dozens of studies of Raynaud's phenomenon, and they looked to see what factors may be contributing to an increased risk of Raynaud's. It was interesting to see that cardiovascular disease and also, and importantly, smoking were 2 of the independent risk factors that increase the likelihood of you having Raynaud's symptoms. So is this primary or Raynaud's phenomenon? So this is a lady in her 40s who presented with sensitivity to cold, and she'd noticed white and blue color changes of her fingers. She didn't have any features of connective tissue disease. All of her laboratory studies were completely normal. And you can see from her thermal images, she's actually does have very warm, well-perfused fingers. Her fingers are actually about 36 degrees, so a little bit cooler than our core, but certainly very different to the case of Raynaud's phenomenon I described last. And there was very little response to cold challenge. Her fingers really rewarmed perfectly normally in the 15 minutes following a local cold challenge. Her Nailfold capillaroscopy also looked remarkably normal. And again, I will be talking more about Nailfold capillaroscopy and how it helps us clinically. But these are very normally shaped and sized blood vessels in the Nailfold capillary. So what I haven't told you here is really her main problems were symptoms that we would associate with fibromyalgia syndrome. And in fibromyalgia syndrome, the brain's pain center becomes hypersensitized. which can cause a number of symptoms, including widespread aches and pains within the muscles. And people with fibromyalgia will also often notice intolerance to other stimuli, such as bright light, loud noise. We sometimes use the term central sensitization syndrome to describe this very common condition. It affects about 1 in 20 of the general population. There are other common features that may be important in the development of this, such as unrefreshing sleep. So people often wake up feeling that they're unrestored after a night's sleep. Fatigue is often a major problem. And you can often get tenderness of the muscles. People with fibromyalgia will often report it feeling painful if someone gives them a big hug. Things that shouldn't be painful are experienced as significant pain because of this hypersensitization of these pain pathways. And this may well extend to cold sensitivity. So the work of Allen and Brown, they noted that a number of their patients reported chronic exhaustion, difficulty sleeping, aches and pains, headaches, features that we would certainly associate with fibromyalgia, spectrum disorders. And if you actually do questionnaire-based studies of people with fibromyalgia, you find a very high prevalence of Raynaud's phenomenon, ranging between 18 and over half of patients, depending on what questions you are asked of those patients. And we've done some studies at our site where we've looked at the blood supply to the fingers using thermal imaging in people with fibromyalgia with Raynaud symptoms, and found actually they often do have quite normally perfused fingers. So the amount of blood flowing into the fingers can appear very normal. And this may be an issue of cold intolerance rather than a true vasospastic disturbance, although we certainly need to do more work to look at the link between fibromyalgia syndrome and Raynaud symptoms. So I think the relevance of all of this really feeds into how we manage our patients. So, if I meet a patient who lives in a cold climate, very low body mass index, I do think a physiological thermoregulatory response is one of the key drivers of this. And no medication we use will completely eradicate those symptoms because, as I mentioned earlier, if the body perceives the core temperature to be threatened, it will override the vasodilator, the blood vessel opening actions of any of those drugs to conserve the core temperature. And so you sometimes find treating patients in this group with vasodilator drugs, that you get quite a high number of drug side effects and sometimes with limited benefits. And certainly I encourage patients to focus more on maintaining their core temperature. And I think that's good advice for anybody with Raynaud symptoms, to think about heated gilets, warming or pre-warming their clothes on the radiator before they leave their house, so they're putting on clothes that have been warmed up. It's not just about wearing gloves, and it's about conserving heat loss from the head and other areas. And then subclinical atherosclerosis, I certainly feel that this is an area that we need to look at more closely as well. But smoking cessation is absolutely essential in this group. And I think, again, for all people with Raynaud's symptoms, whether it's being caused by systemic sclerosis or other conditions, should certainly avoid cigarette smoking, because there are lots of chemicals in cigarettes that will promote, including nicotine, that will promote vasoconstriction. So they'll actually make the blood vessels want to close down. But there are also chemicals that may be key drivers in the development of autoimmunity and pushing these conditions forward, as well as leading to hardening the arteries, which is also likely to exacerbate the poor blood supply to the fingers. So I'm going to shift gears now and talk a little bit about secondary Raynaud's phenomenon. I've already mentioned that secondary Raynaud's phenomenon can be caused by lots of different conditions. And I've listed them here, and often actually the diagnosis of secondary Raynaud's is a clinical diagnosis based on very key distinguishing features. So in the case of hypothyroidism, you may find that people are actually put on weight in the months and years preceding the development of Raynaud's symptoms. People who are profoundly hypothyroid sometimes develop a very typical appearance to their skin that you can see in the clinic setting, and they may have a slowed heart rate. In macrovascular disease, often there'll be a degree of asymmetry, so it may affect one. If people ever present to my clinic with Raynaud symptoms in one hand, that immediately makes me think of macrovascular disease, or certain neurological conditions in which the fault is actually within the limb in which the symptoms are being experienced. For iatrogenic or drug-induced Raynaud's, you need to look at the medications people are taking and then say, look, when did you start that medication? How closely does the timing of the start of that medication fit with the development of your Raynaud's symptoms? So it can be a comparatively simple diagnosis to make if you're asking the right questions. And often, actually, it can be comparatively simple to treat these patients with secondary Raynaud's, because if you know exactly what the cause of the Raynaud symptoms is, then you can target your intervention for the cause. So in the case of hypothyroidism, you can replace the thyroxine that can eradicate Raynaud symptoms. There may be scenarios in which you're able to stop treatments like beta blockers that are aggravating or causing Raynaud symptoms. But I would always encourage you to base any decision to stop a treatment, certainly such as a beta blocker, in conjunction with your healthcare provider, because certainly if beta blockers, if they've been started for conditions like heart failure, stopping them abruptly can actually really unsettle matters. So always make decisions in conjunction with your doctors. This is an example of a case of secondary Raynaud's phenomenon presenting to my clinic. So this is a man who developed fairly sudden onset Raynaud symptoms. There's an image here of cold blue fingers. Also had this lace-like appearance on the back of his knee. And the diagnosis here was a condition called cold agglutinin disease. It's actually a blood disorder in which you develop immune proteins that make the blood cells in the bloodstream clump together, and they can actually clog up the small blood vessels in the fingers and other parts of the skin when the circulating blood temperature dips, and this can clog up the blood vessels and lead to Raynaud symptoms. So by directing our treatment towards the cause of his problems, we were able to considerably improve these symptoms. So what about Raynaud's phenomenon and systemic sclerosis? So this is a case described by Thomas Barlow, who is a physician working in London in the 1880s. And he'd retrieved a copy of Maurice Raynaud's thesis and decided to translate it into English. And after he'd completed that piece of work, he then looked in his own case mix to see if he had any patients with similar sounding symptoms. And he described one case, which was a woman who for 5 years suffered during the winter with hard yellowish patches on the fingers. Things often improved during spring, but actually the fingers were permanently altered, and the fingers became cold, hard, numb, and atrophied. So there was actually some loss of the substance of the fingertips. And the fingers were held in a state of semi-flexion, and then the patient got these ulcers on the ends of their fingers. And any rheumatologist reading this description today knows that this, although Thomas Barlow didn't have the investigative tools to recognize it at the time, but he was describing a case of systemic sclerosis. And I think it was because of descriptions like this that led to Raynaud's phenomenon being used in the context of systemic sclerosis. And Raynaud's phenomenon in systemic sclerosis isn't life-threatening, but it has a major impact on quality of life. This study done in Canada asked patients to list the symptoms that bother them most on a daily basis. And you can see that actually top of the list was fatigue, but the highest disease-specific manifestation of systemic sclerosis was Raynaud's phenomenon. And we know from work we've done with patients with systemic sclerosis that Raynaud's is a major cause of pain, numbness, emotional distress, inability to use the hands properly. It can lead to social isolation. People are unhappy with the appearance of their fingers, body image dissatisfaction, and all of this has a major impact on health-related quality of life. So it's certainly something that we as rheumatologists and people managing people with systemic sclerosis take very seriously. So what's actually going on in the connective tissue diseases to cause these Raynaud symptoms? So the pathological triads of connective tissue disease or autoimmune rheumatic disease is inflammation, so the body's immune system attacking the body, abnormal blood vessel function, and that can be Raynaud's in the fingers, but other organs can be affected, certainly in the context of systemic sclerosis, such as the kidneys and the lungs. In the lungs, we talk about pulmonary arterial hypertension. That's one of the features of vasculopathy of connective tissue disease when it affects the lungs. And then the final pathological feature is fibrosis or scar tissue formation. And in the context of systemic sclerosis, that can be in the skin, leading to scleroderma or thickened skin, but also the lungs, the heart, the GI tract, all affecting the function of those organs. But the abnormal blood vessel abnormalities that we see is caused by actually the immune system attacking the very thin inner lining of the blood vessel. In this image here, on the left of the screen, you can see a normal looking blood vessel, and the paper thin layer of cells in the inside of the blood vessel is called the endothelium, and this is thought to be an important target of the immune system in conditions like systemic sclerosis. And this white patch in the middle of this image at the top is the lumen, the area in which the blood flows through. And you can see that over time in systemic sclerosis, all the layers of the blood vessel become thickened and damaged and scarred, and the actual lumen, the hole in which the blood is meant to be flowing through, actually gets progressively destroyed, so it's very difficult for any blood to pass through that area. So how do we diagnose systemic sclerosis? There is no single diagnostic test that says you definitely have systemic sclerosis and this person doesn't. It's a jigsaw, a constellation of patient characteristics, clinical features, physical findings, and then laboratory studies that help us really diagnose systemic sclerosis. So if people have all the right clinical features, if the blood tests identify these autoimmune antibodies that we often associate with these conditions, they have the right physical findings, and that includes abnormalities in the size of the shape of the capillaries at the nailfold. This really helps us make a diagnosis. One thing that isn't very helpful from a clinical perspective is Raynaud severity. So whilst systemic sclerosis can lead to Raynaud's phenomenon that's so severe it causes damage to the ends of the fingers, digital ulcers, actually Raynaud symptoms themselves can be very similar. So these two thermal imaging studies show two people with Raynaud symptoms, and arguably the study in the bottom of the screen doesn't look quite as severe as the one above, whereas actually the final diagnosis of the case in the bottom was actually systemic sclerosis. And the fact that we even use this term Raynaud's phenomenon to describe what's going on in the blood vessels of the fingers of people with systemic sclerosis, this inflammatory obliterative microangiopathy, so an immune-mediated damage that leads to progressive obliteration of those blood vessels, versus primary Raynaud's, which is very problematic for people who experience it, but where the problem is more one of vasospasm, where the blood vessels are just hyperactive to the cold, but actually are structurally normal. The fact that we use the term Raynaud's to describe both of those conditions may be something that contributes to diagnostic delay. So SRUK helped fund a study of the CPRD, which is a huge database of primary care records of people living here in the UK. And we identified nearly 1,800 people with systemic sclerosis in the CPRD. And we looked for cases in which patients had been along to their GP to complain of Raynaud symptoms before they were eventually diagnosed with systemic sclerosis. And about half of the patients in the CPRD had actually been to their GP with symptoms of Raynaud's before they were eventually diagnosed with scleroderma. And in about a third of those cases, the gap between them seeing their GP for Raynaud symptoms and getting a diagnosis of systemic sclerosis was less than a year. So that's encouraging to see. What was worrying was that half of patients waited between 1 and 10 years, and about a quarter of the patients, there'd been over 10 years from them first going along to their GP and saying, I think there's a problem with my fingers. They're very sensitive to cold and they're changing colour. And the GP correctly identifying those symptoms as being Raynaud's phenomenon and telling them they've got Raynaud's phenomenon, but they're not realizing that there was an underlying health condition like systemic sclerosis driving this. So these are people who've been falsely reassured, really, that they've got just Raynaud's phenomenon. The typical history I hear from patients is, I did go and see my GP, but they said, oh, this is just Raynaud's phenomenon. Now, before any of you think I'm being unkind to GPs, I'm going to stick up for GPs, because a large GP practice of 10,000 patients would have 500 people or more with Raynaud's phenomenon symptoms, and the vast majority of those people will have primary Raynaud's phenomenon. So that same large GP practice of up to 10,000 patients probability would suggest we'd only have 1 or maybe 2 people with systemic sclerosis. So the challenge is, how do I identify which people within these within GP practices have this rare but important underlying autoimmune rheumatic disease? And this is where Nailfold capillaroscopy can really help us. So it can help differentiate between primary and secondary disease. And that's traditionally how this tool has been used. But actually, I think it can also give us some prognostic information. And I'll talk a little bit about that now. So what is Nailfold capillaroscopy? It's actually a very simple procedure. It's a microscope with a light source. You can see the light shining at the bottom of the device here. And it allows us to look at the blood vessels at the cuticle of the Nailfold at 200 times magnification. It's completely safe, painless, and the images appear there directly on the screen. So when I do Nailfold capillaroscopy in the clinic, I'm able to talk patients through what I'm seeing and what that means. And the area we're examining is this area here at the cuticle of the Nailfold. And it's actually one of the few areas of the body where we can directly visualize the blood vessels in the body. And we typically assess 3 or 4 of the fingers on each hand, and we'll obtain 3 or 4 images per finger. So you can't just put it on once and then say, yes, this is normal. You do have to, certainly early in the disease course, it's important to look at multiple fingers. So the normal Nailfold capillary or Nailfold capillary size and shape, you get these uniformly spaced capillary loops that look like little hairpins going up and down. And when these are damaged by the immune system, when the endothelium is damaged, the blood vessels expand in size. It weakens the integrity of the blood vessel wall, allowing the blood vessels to become considerably enlarged. We call these giant capillaries, and they can then pop and start to bleed, and we see these are little microhemorrhages that we can actually see in the Nailfold. So these are the changes we're looking for when we meeting people with early disease. Later on in the disease, when those capillaries have been damaged, you can end up with large areas of the Nailfold where there doesn't appear to be any capillaries at all. And if you do see capillaries, often they're very abnormally shaped and sized. We call these bushy capillaries because the capillaries are heading off in all sorts of directions, like the branches of a bush. And that's evidence of aberrant new blood vessel formation. So the body's recognized that there isn't enough oxygen and nutrients reaching these areas, starts creating blood vessels very quickly, which are often very abnormally shaped and sized. So this is a typical referral to my clinic, lady in her 70s. So that's a red flag for secondary Raynaud's, because nobody should be developing Raynaud symptoms at that age. She also developed an ulcer on one of her fingers. She didn't have any skin thickening or other skin features of systemic sclerosis. This is her thermal imaging study, again sped up over about 15 seconds. So the fingers fairly poorly perfused at baseline, but they go very cold after a local cold challenge, and they stay cold over the 15 minutes following this. And her Nailfold capillaroscopy was also very abnormal, with significant capillary dropout, some abnormal new blood vessel formation, and giant capillaries. So even though this person doesn't have any skin thickening or scleroderma, they certainly have systemic sclerosis. And these are the cases I showed you earlier. You can see that whilst the thermal images and their Raynaud symptoms didn't differ between primary and secondary Raynauds, actually the Nailfold capillaroscopy really helps you to differentiate between the two. And we use these tests, Nailfold capillaroscopy, as part of the way we classify Raynaud's phenomenon. And somebody with Raynaud symptoms, abnormal Nailfold capillaries, and one of the systemic sclerosis related antibodies, whilst they wouldn't fulfill the classification criteria for systemic sclerosis with just those features, we know from a number of studies now that there's an 80% chance of them developing systemic sclerosis, full-blown systemic sclerosis, within the next 5 years. So in terms of prognostic value of Nailfold capillaroscopy, there's been some very important studies done in recent years. This study looked at 140 systemic sclerosis patients, followed them up annually for 3 years. Actually, half of the patients, their Nailfold capillaroscopic changes just didn't change over that period. Their disease remained remarkably stable. But in the other half of patients, there were changes that occurred. Now, in some of those patients, the changes were positive. There was actually an increased number of capillaries. And those who developed more capillaries were actually less likely to develop new digital ulcers on their fingers. But if there was a significant loss of the capillaries over time, this was associated with a 5-fold increased risk of new ulcers, 18 times increased risk of features of pulmonary arterial hypertension, and a 4 times increased risk of progressive skin thickening. So the active loss of capillaries over time may well be giving us very important prognostic information as to how the disease is likely to evolve over that same period. And I think there is value in using this in the clinical practice. So we know that when we start talking to people with Raynaud's phenomenon and perhaps a scleroderma antibody like anti-centromere antibodies, and we tell them about systemic sclerosis, we know they'll go away and Google this, and it can be very fear-provoking reading about conditions like systemic sclerosis. So this is a lady with an 8-year history of Raynaud's phenomenon, carrying anti-centromere antibodies. But when we did the Nailfold capillaroscopy after 8 years of follow-up, she still had beautifully preserved capillary density and just the occasional giant capillary. And I think this is telling us that from a pathological perspective, her disease is also not progressing and remains fairly quiet. And I think my expectation is this would be associated with very good prognosis. There can be challenges performing Nailfold capillaroscopy, particularly in people with high levels of pigment in their skin. So brown and black people can be quite difficult to obtain good images, but actually with time and effort, you can usually obtain good enough images to decide whether or not there are abnormalities present or not. Sometimes people, if they've been to a nail bar and had work done on their cuticles just before their study, it can make it very difficult to actually assess the capillaries. And what we're seeing here is on the right of the screen is the capillaries swimming up to the surface and then swimming back down, and we're seeing them kind of end on rather than nicely laid out for us. So it can be more difficult to decide whether or not they're abnormal. And we run I've recently, or when I say recently, a couple of years ago, moved to Bristol, and one of my priorities on moving there was to set up a Nailfold capillaroscopic service to help with the diagnosis and assessment of people with Raynaud's phenomenon. Just a couple of words on treatment. You'll see this is now a few years old, and actually they've just published an update to the EULAR recommendations on the management of systemic sclerosis, which includes a section on how do you manage scleroderma-related Raynaud's. I mean, there's only 4 different medications listed here as treatments that can be considered for Raynaud's phenomenon. Dozens of treatments have been tested over the years, and one of the difficulties we've had is being able to measure Raynaud's phenomenon effectively to identify those treatment benefits. In terms of how do we go about managing people with Raynaud's phenomenon, the UK scleroderma study group came up with a consensus best practice approach for managing Raynaud's, and actually just in the last month or two we've published updated BSR guidelines on the management of systemic sclerosis that includes how do you manage Raynaud's. You'll see there's a huge, the whole first section of this is all around general and lifestyle measurements, avoiding cold, maintaining and conserving core temperature, avoiding smoking, treating any underlying causes. And then we have lots of different treatments that we can add in that will help encourage those blood vessels in the fingers to open up. And it's interesting actually reading these guidelines, which are less than 10 years old. There are already significant changes to this in terms of the positioning some of these treatments. So these PDE5 inhibitors include drugs like Viagra, and we're using those much earlier on in the disease course when managing people with scleroderma-related Raynaud's. So hopefully in the last 45 minutes or so, I've helped you understand more about the term Raynaud's phenomenon, the fact that we use this same term to describe a very large breadth of digital vascular problems. I think primary Raynaud's is far more complex than we originally thought. The management of Raynaud's should focus on the main atiopathogenic drivers, so the things that are causing the Raynaud's. And I was saying primary Raynaud's, that may be really about focusing on core temperature preservation. Scleroderma-related Raynaud's is a major cause of disease-related morbidity. So it's just another way to makes patients' lives miserable, and it's something we should be doing as much as we can to help them with. We do have effective tools to help differentiate between people with primary Raynaud's phenomenon and Raynaud's caused by systemic sclerosis. And there are treatments that we can use to promote opening up of blood vessels in the fingers, which we certainly use in clinical practice. And with that, I'll be happy to stop sharing my screen and take any questions that you have.
Hi. Well, thank you for that. That was very, very interesting. So we have already had a few questions in already. People have just asked if it's possible to have the slides after the session. And I will say this is being recorded and will be put on our YouTube, so you can always watch it back and see them there. People have asked if putting on weight is possible to improve secondary Raynaud symptoms.
Yeah, I think it is something that would potentially help. And we often worry in systemic sclerosis around people being underweight. That is a concern for us as doctors. One of the reasons we weigh people when they come along to the clinic is to make sure people aren't losing weight as a result of GI involvement in systemic sclerosis. It's something that can reduce people's ability to effectively fight off infection, and it's important to have a reserve that we can call upon if our body is under significant stress. Having said that, it is also important that we maintain a healthy weight, and we wouldn't encourage patients to run high weights or be overweight because of the increased risk of diabetes, cardiovascular disease, breathing problems, mobility issues, or which we associate with people with raised weight. So people should aim to have a healthy weight, but having some fat tissue, adipose tissue, will help us conserve our core temperature, and that will encourage the blood vessels and the fingers to open up. But there are lots of other things we can do, and I've had some good feedback from patients from using these battery-powered gilets, so these electric gilets, which you can press a button to warm up the core to encourage the blood vessels to open up.
Similar to that then, just a quick question about, could weight loss trigger systemic sclerosis to progress more rapidly? Do you know if that's been something looked at?
It's a really good question. I think in terms of what's going on in the immune system and the way the immune system's attacking the blood vessels, I don't think sudden weight loss would aggravate that. Having said that, we do think that some of the complications we associate with systemic sclerosis, the emergence of digital ulcers, the emergence of the little red spots, the telangiectasies, maybe calcinosis as well, the little hard lumps of calcium that can be deposited in the skin. We think these all occur at areas where there's a very poor supply of oxygen and nutrients to the tissue. So if people are underweight and their body is, or their brain is sending signals to the blood vessels in their fingers to clamp down, to close down and constrict, on top of them having systemic sclerosis, that could aggravate some of those other manifestations of systemic sclerosis.
Yeah. Just a question about if there is a link between Raynaud's, hypothyroidism, and scleroderma, or are they just both linked to Raynaud's?
Yeah. No, so we often find that people with autoimmune rheumatic diseases like systemic sclerosis have other organ-specific autoimmune conditions like hypothyroidism. And about a quarter of our patients with systemic sclerosis have hypothyroidism. So there's definitely a link there between the two. But providing their TSH is within the normal range and they're getting the right thyroxine dose, then that should treat any aspect of the Raynaud's that was thyroid induced.
Oh, I see. There's a question here, just should everyone have a Nailfold capillaroscopy?
I think so. No is the short answer because Raynaud's phenomenon probably affects 5% of the population of the UK. So probably over 3 or 4 million people in the UK have Raynaud's symptoms, maybe more, depending on whether they live up in the top of Scotland or down in the south. So it's too common for everybody to have Nailfold capillaroscopy, but any high risk groups definitely should have it. So, and I think the simplest factor that should influence how hard you look for secondary Raynaud's is the age of Raynaud's onset. Anyone who develops Raynaud's symptoms over the age of 30, to my mind, has secondary Raynaud's phenomenon, and you should be thinking about a secondary cause. Now, that secondary cause could be that they've lost a load of weight, and we see that in people post-bariatric surgery will often report an increased occurrence of Raynaud's symptoms. But you have to have an explanation for that, and that is the group of patients who I think we should be considering blood tests, laboratory tests to look for some of the antibodies we associate with systemic sclerosis, and consideration for Nailfold capillaroscopy to make sure that there isn't something going on in those blood vessels that's causing damage to them.
Yeah. Bit of a diversion, but can primary Raynaud's affect the helix of the ears?
Yes. So the number of common body sites affected, and they're often what we call the peripheries or the extremities. So the areas of the body quite far away from the heart or the core. So it can affect the ears, the nose, the fingers, the toes, and also the areolar tissues around the nipples can be a major body part affected, particularly in primary Raynaud's phenomenon. Interestingly, less significantly so in secondary Raynaud's, like systemic sclerosis.
Yeah. Okay, we'll just have time for a few more questions. So apologies, but we won't be able to get to all of them. But is there ever been any studies on how many attacks are stress-related rather than cold-related?
Yeah. So stress-related Raynaud's phenomenon is an issue in primary and secondary, but it appears to be more of a problem in primary Raynaud's phenomenon than systemic sclerosis. So when we're stressed, we release hormones that encourage blood vessels to clamp down. And so regulating our stress and anxiety levels is probably an important thing to do.
Just to follow on from what you answered about the previous one, someone's just asked if the late 20s would be a concern area for secondary Raynaud's, or is 30s a hard cutoff?
Yeah, there is definitely no hard cutoff because people can be diagnosed with systemic sclerosis in childhood. So, an 18-year-old presenting with Raynaud's symptoms, I would never say, oh, it's just going to be primary. You have to listen to the story of the other features here that I would consider a red flag for a condition like systemic sclerosis. So puffiness of the fingers, the new emergence of gastroesophageal reflux, so reflux symptoms in the gullet, and certainly the development of any sores on the fingers. That is something that we shouldn't see in primary Raynaud's phenomenon and can be a feature of secondary. and should be investigated fully.
Yeah. So just, is it possible to have Raynaud's with no color changes?
Yeah, I think it is. And if you look at systemic sclerosis registries, they suggest that about 5% of people with systemic sclerosis don't have Raynaud's phenomenon. Now, my personal feeling is that you almost can't have systemic sclerosis without having some level of impaired circulation in the fingers. And most patients will report cold sensitivity and color changes. But we know that about 1 in 10 people with systemic sclerosis will only report blanching, whitening of the fingers. And if you strictly apply the classification criteria for Raynaud's that requires you to have 2 color changes, then you're going to miss those patients. So I think, there are patients who, will may not fulfill the classification for Raynaud's, but will still have some form of vascular dysfunction in the fingers. I think there is a very small number of people with secondary Raynaud's or systemic sclerosis who just don't report any symptoms, but they may still have abnormalities in Nailfold capillaroscopy.
Oh, interesting. Just one final question about ginkgo biloba. I can never pronounce that. Just, is there any problems with taking that, or is it something that should just be seen as a positive?
Yeah, I can never pronounce that one either. And I think it's lots of patients are interested in what supplements they may use. So there can be a quite reasonable reticence to use drugs on a regular basis, and I think that's can be a very sensible approach. But so ginkgo comes from the ginkgo tree, and so it's a natural remedy that is thought to improve the blood supply to the fingers, and certainly patients will often derive or report some benefits since starting that. I have absolutely no trouble with patients trying different herbal and supplementary remedies for the Raynaud's, but just let your doctor know that you're trying them, just because occasionally these things can interact with some of the treatments we may be using to manage other aspects of their scleroderma.
Thank you for that. Yes, so unfortunately we're not going to get time to get to all the questions, but I will write them down and then see if we can get back to everyone after this. But thank you, Dr. Pauling, for that very interesting presentation. And I know from the comments that everyone else found it very, very helpful. And I'm sure everyone did enjoy it. So just before we go, I am just going to give a short presentation about our updated STAR app, just to let you guys know. So just bear with me one moment. I'm just sharing my screen and I'll just give you a little bit of this heads up. So essentially, we have, to better understand this condition and support people living with Raynaud's, SRUK have developed the STAR app, the symptom tracking app for Raynaud's. Just going to talk about it very briefly here, just to guys give you a heads up that it is going to be available to download later this year, free for everyone on their app store. So STAR is a symptom tracking app which allows people living with Raynaud's to track their symptoms of their attacks, monitor changes in the condition over time. So you'll be able to track the severity, frequency, duration, and triggers of the attack, as well as some of the physical and psychological symptoms which are connected to the condition. You can also keep track of lifestyle factors that we know are associated with Raynaud's, such as smoking, alcohol, caffeine intake, and levels of stress. So the data that users contribute to the STAR app will be used to allow SRUK to better understand the ways in which our community are affected by Raynaud's throughout the year. And it also has the potential to enable us to support research into the condition. So here you can see what the app looks like and some of the trackers that are available for users. So this, for instance, is the daily summary tracker. So with the STAR app, we firstly want to empower people basically living with Raynaud's by providing insights that will help you track and better understand different aspects of the condition. And by using the app, you can log certain symptoms about how they've affected you over a period of time. And so you have a clear record and understanding of your symptoms. And by having a physical record of your symptoms, we want the app to make it easier for you to clearly communicate the various impacts of your Raynaud's to your healthcare professionals. We know a lot of people find it really useful to have a record of symptoms that you can look back at after an appointment and before an appointment. So you're able to give a clear account of the symptoms you've experienced, how badly they've affected you, and really flag what you're worried about. And we also want to use it to improve our own understanding of the condition and how it impacts the community. It's essentially really crucial that we do know how our community are being affected by Raynaud's on this type of daily basis. And with this insights, we can use it to support research. So what have we learned so far? Basically, the app actually did launch in early 2022 with a cohort of around 300 patients. And since then, we've been able to have a lot of data and research. So for instance, 37,000 tracker updates, as well as 8,300 daily summaries. We recognize that from this, we've been able to really find better understanding the impact of the condition. So learn about, like I said, the frequency, severity, duration, and triggers of people's attacks at a real-time basis. It's really just helped us understand how people are affected all year round rather than in the worst case scenarios. So this just shows a bit of the data that we have collected over the course of the years. I won't go into detail on this, but you can see how this data is important for us to hold, as it's something that's not tracked on this scale a lot of the time. So we do recognize that we would like to expand the app, and this is what I'm talking to you about. We would like to give other people the chance to participate, track their symptoms, and contribute to anonymized data. So like I said, this new version is due to launch later this year and will be free for everyone to download and use. So with developing this new version of the app, we have added some new features. Users will still be able to track their symptoms, the impact of their attacks, and the daily summary, as well as the duration of the attacks, the level of pain experienced, the impact of the function of the hands, their mood, stress, and anxiety. You'll also be able to track which parts of your body were affected, if you know what triggered your attacks, and how you modified your behavior as a result of the Raynaud's. Another new feature is the medication tracker. And this will allow you to track medications you've been prescribed for your Raynaud's, so you can track the dosage, keep a record of any perceived side effects, and how well you think the medication is working. And we really do hope that this will be a useful tool for discussing treatment options with your healthcare professionals. We also want to help facilitate research into Raynaud's. And so we were doing seasonal research questionnaires put out 4 times a year, where we ask everyone who's using the app to take this questionnaire, so we do get an idea of not just people who experience Raynaud's quite severely, but people who experience milder symptoms only at the colder parts of the year. This will really give us a good insight into the impact of the condition. It is important to note that all the data contributed to the app, including these through the seasonal research questionnaires, is completely anonymized. So we will never be able to identify you as a result of the data you provide, and we will never contact you regarding research initiatives without your express consent. And finally, the other new thing is that there is going to be an Insight tab where users can browse insights and see general trends in the data collected through STAR, so you can compare your own symptoms to what the general trends are. And so just finally, if you're interested in using the new app or finding out more information, you can email Raynaud's app support at SRUK, and we'll send you a link to download the app on launch. Please also do keep an eye on our social media channels, and in our e-newsletter, we'll be letting you know as soon as it's available to download. So thank you everyone for just allowing me to share that with you all. Keep a lookout, like I say, for more information. Yes. So once again, thank you, Dr. Pauling, for joining us today, and I hope everyone had a good session. No worries. All right. Bye, everyone. Thank you.
Thank you.